Hello, friends. Good morning. I'm Dr. Gina Mistry. I'm an MD pharmacologist. Welcome to my YouTube channel. So this is this part 2 of antimicrobial therapy series of a general principle. So this is the table of contents. Like I'm already covered the introduction, types and role, and the pharmacokinetic parameter in the previous video. So this in this video, I'm telling about the how the impact of susceptibility testing, the culture and sensitivity which are impacting the antimicrobial agents, then its results, then which are the various dose selection, dosing intervals of that particular antibiotic are required. And the last, what is the mechanism of resistance? Why the antimicrobial resistance are occurred? Which are the various factors that are affecting it? So let's learn in the further slide. So this is the impact of susceptibility testing on the success of that antimicrobial agent, and it is the major factors. How that selection of that antimicrobial according to that susceptibility or in the resistance, it's really helpful that antimicrobial effect for particular disease. So this is the how that drug register the resistance of that particular drug which affecting based on that particular susceptibility testing and how it affecting, right? So this is the graph which are showing the changes in the sigma of Emax model with the increasing the drug resistance. Before I'm explaining this graph, I'm telling about some basic thing for the microbiological analysis. So the microbiological laboratory plays a central role in the decision of to choose a particular antibiotic agent over the others, right? So first, there is a need to be identification and isolation of that pathogen or maybe the culprit organism to take place. The patient specimen are sent to the microbiological laboratory. Once this microbiological species causing the disease has been identified, the more rational choice of that class of antibiotic likely to work that patient should be made. Right? So we should to decide that which this antibiotic is for this indication. The next thing that is the microbiological laboratory, then having the same role to identify the antibiotic, to identify what antibiotics the organism isolated from the sample is susceptible to, and they are allowing some definitive therapy to that microorganism. So we are say that the million of individuals across the globe become infected by many different isolate of that same species of the pathogen, and evolutionary processes also there. So they make slightly different from the next, so that each other have a unique susceptibility of that particular antimicrobial agent. So we are dividing that patients undergo further evaluation between the time of infection and the time of diagnosis also. So they are observe the distribution of concentration of antimicrobial agent that can kill that pathogen. So this is based on that susceptibility pattern. Okay, so because the antimicrobial agent ligands are bind to that particular target site to produce the effect, the relationship between the drug concentration and its effect on a population of an organism is modeled using the standard field type of the receptor and its agonist, right? And this is the sum having the characteristics. I'm saying some parameter like what is the IC50 or EC50, also termed it's EC50. So this is the inhibitory concentration or maybe effective concentration, that is the 50% effective measure of antimicrobial agents potency, right? Like 50% of the concentration where the microbiological organism that kill, right? This is the IC50. What is Emax? So this is a measure of maximal effect. And the H, that is a slope of curve or a hill. So now we are sure that this is the antimicrobial agents effect versus its response graph, right? Showing in the x-axis versus y-axis. And first graph showing that increased in the resistance may show changes in the IC50, right? If drug resistance have increases in particular time and duration, if the time of infection to the time of diagnosis may be variable, right? So why that is the increase in resistance, which is affecting the IC50 of antimicrobial agents. So in the graph A, that is inhibitory concentration at 50%, right? At 50% this. which is increasing from the 70 to the orange line, right? 70 to orange line. Then in the 100, right? In the 100, that is the green line, and in the 140, like this is the increasing in the loss resistance in the blue line, right? Same thing, an increase in the resistance. This is increasing in resistance may show the decrease in the Emax. If the resistance is increasing according to the durations or maybe the longer prolonged use of the antibiotic, the Emax of that antimicrobial agent is decreased, right? So in the B, that is efficacy response is decreased from full response orange line to the 70% in the green line. So this is the effect response which affected if the drug resistance is offered, and in this the potency of that drug, right? This is the how the potency of the drug is higher in case of orange line than is decreasing in the green and further on. So the inhibitory concentration at which the antimicrobial agent can kill the microorganism. So this is increased if there is a drug resistance is there. So this graph is showing that how the drug resistance that affect the inhibitory concentration at 50% as well as the maximal effect of antimicrobial agent. So we should to learn about that how the microbiological analysis which help for the detecting the resistance as early as possible, and we are choosing the definitive therapy. So prevent this kind of drug resistance to that patients and for particular pathogen. So this is the antibiotic susceptibility testing method. One is the disk diffusion test, and second that is the dilution test, right? So how that testing that affecting the particular bacteria, viruses, and particular microorganism, right? So for the bacteria, the disk diffusion test, we are taking some solid agar plate, which is covered with a loam of bacteria. Here we are growing the bacteria growing according to the 12 to 24 hour, maybe 48-hour incubation period. And this antibiotic impregnated disc are placed on it. First, we are incubated this agar plate with the bacteria, and then we are putting this antibiotic impregnated disc, right? So now the area around the bacteria is without a visible growth, that is the zone of inhibition, and this is used for susceptibility testing. So I'm saying that this is the antibiotic disc. This is first line, this is the second, and this is third. So third line, that is the zone of inhibition. First, that is the susceptibility, and second, that is the intermediate. This is susceptible, intermediate, and resistance. So if this is the bacteria, like I'm saying that this is the meropenem, like meropenem antibiotic. This is a meropenem. So at this rate, that is a say that like some of the range, at that time the drug can be, the meropenem is susceptible to particular pathogen. If uh, it can be in this zone of bacteria, they can be intermediate sensitivity or susceptibility to that antimicrobe to particular microorganism. And this is the zone of inhibition. At that time, at that point, the meropenem kill the microorganism at this point. After that, if there is a bacteria grown here, they cannot be inhibited by meropenem. So this is the range of that anti-meropenem antibiotic, right? After that is the minimum inhibitory concentration. After that, if you are giving the higher dose or even the more interval, but the bacteria cannot be. So this is based on the site of infection. So how the pathological compartment can affect it, and how that particular drug can affect particular zone of inhibition. So this is the zone of inhibition. So this is the different antibiotic then affected, like 11 mem, like peptides, like peptidacillin, tazobactam, meropenem, amikacin, ciprofloxacin, ceftazidime. This is the inhibitory zone, cefepime, then gentamicin. So this is the disk diffusion method, how the susceptibility test can done. The second thing, that is the dilution method, right? We are the minimum inhibitory concentrations. So this is the different dilution tubes we are incubated with the visible. This is showing some visible bacteria. So x-axis showing the antibiotic concentration microgram per ml, and in the test tube there is a visible growth of bacteria is seen, and after that there is no visible growth are there. So this is said that minimum unit concentration is 1 microgram per ml of particular agent. So after that there is the no any antimicrobial grown. So this is how the antimicrobial agent can affect or kill the microorganism. At if we are giving 0.5 microgram per ml, there is no any um, uh, kill of that microorganism, and still the disease may be progressed even after you give that 0.5 dose of antibiotic, right? So we need to be choose the proper dose according to that site of infection and peak plasma concentration also, right? So here say that the sample that is of bacterium is added, like how that I'm saying that process of how that disk dilution testing is done. The sample of bacterium is added to the micro titer plates and containing the variable concentration of antibiotic of interest. So we are say that here the antibiotic is already here put it, right? And bacterium is also grown in that plate. So after the incubation, the valves with the lowest concentration of agent that has prevented the visible growth are considered. So this is the how the lowest concentration, like that is 1 microgram per ml, at which that has prevented the visible growth, that is considered to represent the minimum inhibitory concentration for drug organism pair, right? Drug organism pair. And if the MIC is less than the clinical breakpoint, the isolate considered to be the susceptible to that antibiotic. So I'm said that this is the clinical breakpoint, and this is the minimum inhibitory concentration in the blue square, right? So if there is the clinical MIC is less than the clinical breakpoint, so we are say that this is the piperacillin is susceptible to particular organism. But if there is the clinical breakpoint is like 0.5, and this is minimum inhibitory concentration, right? So ciprofloxacin is resistance or maybe the intermediate range. If there is a one, there is intermediate, and there is two, there is the inhibitory, right? This is the resistance because the clinical breakpoint is more than the MIC. So we said that the ciprofloxacin is resistant to particular organism. So this is the second dilution test. So this post microbiological test help to identify the culture and sensitivity of that particular bacterium or and microbial agents versus the which drug should be susceptible, maybe the intermediate and resistance according to that minimum inhibitory concentration. So this is the how that particular impact of susceptibility testing on the success of antimicrobial agent, which is helpful for the clinician to choose that antimicrobial agent according to that susceptibility testing. Next thing is the basis of selection of dose and how the dosing schedule can be done, right? So this is the graph showing the effect of different dose schedule on the shape of the concentrations versus the time curve. So how the this is the drug x-axis showing the time in the hours versus the y-axis on the drug concentration, and how that area under curve and like dosing schedule and dose which affecting these parameters like that which is affecting that particular parameter, right? So before I'm going to that particular graph, I'm saying that the what is that basis of dosing selection. So susceptibility, although the susceptibility testing in the laboratory is central to decision making, but it does not completely predict the patient's response. We are already say that susceptibility testing of laboratory is done, but that is not predict the patient response. In susceptibility testing, the drug concentration is constant. By contrast, in patient, those having the drug concentration is dynamic, even ever changing, right? So we are still not that this is a susceptible, but the particular dose, it's susceptible to that particular patient. So concentration is dynamic and ever changing. So based on that antibiotic are prescribed at certain schedule, like 3 times a day, once a day, twice a day, right? So that is the periodicity in the fluctuation of drug at its site of infection and the microbe which is exposed to that particular safe concentration time. So, in the historical aspect, I say that the Harry Eagle, which has performed the penicillin and discovered the shape of concentration time curve, which is important for that efficacy of that penicillin, right? So this is the important observation. But now that evaluation and some other scientists like William Craig and his colleague, which was they rediscovered it and performed the systemic studies on the several antibiotic, which is initiating the era of antimicrobial pharmacokinetic pharmacodynamic parameters. And this is really helpful in microbiological, like mycobacterium tuberculosis or in the HIV patient. So I'm giving some example of that. Consider of antibiotic with a serum of half-life of 3 hours that is being used to treat the bloodstream infection by the pathogen with a minimum inhibitory concentration of 0.5 milligram per liter. So this antibiotic administered with the dosing interval of 24 hours, like once daily dosing, which is showing in this. So we are say that minimum inhibitory concentrations, this is a 0.5 milligram per liter, and by this bacterial infections of pathogens, which is a treating and which is showing the half-life of 3 hours, like half-life of 3 hours. This is the half-life of 3 hours that particular antibiotic kill that reaching the peak plasma concentration, and there is the dosing interval of 24 hours. So once daily dosing is showing. So this is the how the area under curve is 0 to 24 hours, right? How that making that this is the peak plasma concentration, and this is the time to require that particular achieve the minimum inhibitor concentration. So this is the time is more than the minimum inhibitor concentration. Okay, so this is the graph suggesting of this. So this concentration time curve of antibiotic with the definition of maximum plasma concentration, area under curve, and the fraction of dosing interval for which the drug concentration remain above the MIC. So drug concentration, this is the minimum inhibitor, and drug concentration is above the minimum inhibitor concentration. So the AUC is a measure of total concentration of drug, and it is calculated by taking the integral between the two time points, right? So 0 to t, 0 to 24, and it is the concentration of drug. So this is how the area under curve that we can achieve. So now this is a graphic. In the graph to be if one were changed to the dosing schedule of the same antibiotic, like so we are changed this antibiotic like 0 to 8 hour, 8 to 16, and 16 to 18. It's the same antibiotic, but we are changing the time, right? Like 3 times a day rather than the 1 times a day. In the and these are splitting in the 3 equal doses like 0, 8, and 16. So the shape of that concentration time curve changes to shown like this rather than this shape is different, right? Okay. So because the same cumulative dose has been given for the dosing interval of 24 hours, the AUC 0 to 24 will be similar whether it was given once a day or 3 times a day. For the same pathogen, therefore, the changes in the dose schedule does not change the area under curve upon the minimum inhibitor concentration. So how we are saying that the maximum plasma concentration will decrease by a third when the total dose is split, right? So if we are divided in the three, so this dose is the area under curve is decreased as compared to the A, right here. So here the decrease is. So plasma maximum concentration divided by third. And the next thing, when a dose is fractionated and administered more frequently, so maximum plasma concentration of the MIC ratio will be decreasing, right? So this is also the ratio of AUC upon the MIC will be maximum plasma concentration to the MIC is decreasing. In contrast, the time, this is the about the maximum plasma concentration. The second, the time. So the time that drug concentration persists above the MIC will increases with the more frequent dosing in interval, right? So we are say that here the 0 to like this time, and the above the MIC, the time is taking the achieve the drug concentration above the MIC is also increasing, right? With the more frequent doses as compared to this, right? So more, and despite the same even the dose is similarly administered to that particular agent. So some classes of, so this graph, like I'm concluded that some classes of antimicrobial exert greater antimicrobial effect when their concentration persists above the MIC for longer duration dosing interval as shown in the graph. Indeed, the increasing the drug concentration beyond the 4 times, 6 times the MIC, that does not increase the microbial care for such antibiotic. I'm giving some example like beta-lactam antibiotic like penicillin. And the second, that is the antifungal agent 5-fluorocytosine. So if we are giving 5 times, 6 times, that doesn't mean they are killing the more antimicrobial agents. So these are the biochemical explanation of this pattern, the clinical implication, and however, if that drug is optimized, the time is more than the MIC should be dosed more frequently, given as a prolonged instead of the rapid infusion, or it's having the half-life when the half-life is prolonged by the other drugs. Like I'm giving some example, like co-administration of probenecid with co-administration of penicillin. So the drug concentration persists above the MIC as long as possible. So the effectiveness of that penicillin due to that probenecid is enhanced, but it is given in the continuous infusion. Other example I'm giving like ceftriaxone. So it's having the half-life of 8 hours. At that time, we are infrequent dosing is still allowed to maintenance that adequate time above the MIC, right? And the third example is the HIV. In the HIV, that is the protease inhibitor, which is the boosted, often called boosted with the ritonavir and or cobistrate. So this boosting inhibit the metabolism of protease inhibitor, right, by CYP-A34 and CYP-A2D6, thereby prolonging the EC95, right? Effective concentration at 95%. So this is the how that affected particular um, antimicrobial dosing and dosing schedule, which affecting the um, different schedule and this concentration time for particular antibiotic effect. Some of drug having that one of the terminology like post antibiotic effect and cumulative dosing, right? So in the big like I'm saying that some of that antimicrobial drug having the time dependent killing and dose dependent killing, those having some kind of that longer duration of that post antibiotic effect, which also effectiveness continuing the long after the antibiotic concentration below the MIC. So such kind of antibiotic are also there, right? Which is helpful for killing that particular microorganism. Some of drug having the cumulative dosing adding, so this also maybe affect that microbiome MIC also. So I'm sorry for this is the toughest, but yeah, the how the dosing schedule of once a time a day and 3 times a day, which is affecting the microbial care, right? So some of that drug having the once a day, like 24 hours, some of that once a weekly also, and some of antibiotic needed the 3 times a day, twice a day, right? Like I'm giving you some basic and common example of macrogel, right? That is used metronidazole that is used 3 times a day also, right? So this is the how that dosing selection and its schedule which affecting that particular effect of the drug according to that minimum inhibitory concentration. So last, that is the mechanism of resistance to that antimicrobial agents. So this is the main thing, how that resistance should be done and how that affecting the antimicrobial agents, right? This is the how the mechanism. So this is the different mechanism are there, which is affecting the resistance. Before that, I'm giving some basic ideas about that how that mechanism is affected. Like antibiotic were viewed a miracle to cure the first introduced to the clinical practice. But evading of that penicillin history, right? Resistance eventually developed and deemed the luster of that molecule. Okay. So today is the major class of antibiotic is associated with the significant resistance. I already said that in the previous video that is the high India has the highest antibiotic resistance according to the other compared to the other countries, right? So we need to learn how that the resistance can develop when microbiological species is subject to that existent threat, right? Chemical or otherwise, the pressure will select the random mutation in the species of the genome. Based on that particular chemical reaction, some other pressurized things which is affecting the mutation of that genome. So at that time, we are a major, we are need to be learn that how this is the different mechanism, like reduce the concentration of antibiotic to its target site, then production of a microbiological enzyme that alter or destroy the antibiotic, then alteration of antibiotic target, in ways that reduce the antibiotic affinity. So these are the various factors which causing the antibiotic resistance, right? So first, that is the resistance due to the reduced concentration of drug at its target site. We are like sometimes we say that we are giving some proper doses, like metronidazole giving the 400 milligram, but that doesn't necessarily that the concentration time curve or it shape is maintained particular time or over a prolonged duration, right? To its particular target site. So what is the reason? So one is the terminology like we are calling the small pore molecules, which is including the many antibiotics which enter the cell through the porine channels, which is called porine. So these channels we are really affecting that reducing the drug concentration, right? So absence of mutation in or loss of the favored porine channel can slow the rate of the drug entry into the cell or prevent the entry altogether. If foreign channel mutated, right? So at that or lost that foreign channel, if we lost that foreign channel. So at that time, the resistance of antibiotic to particular microbiological channels, that is the occur, right? So if the target having some intracellular and drug, it requires active transport across the cell membrane. On if there is a mutation or phenotypic change can occur, so at that time the resistance, like cross resistance, can occur. So once the antibiotic crosses the cell membrane and its concentration may be reduced below the effective concentration through the action of efflux pump. So energy dependent transporter that expel the antibiotic to which the microbe would otherwise be susceptible. So this is the five major system of efflux pump, which is helpful. They are relevant to the antimicrobial agent. First, that is the multi-drug and the toxin extruder. The second, that is the major facilitator, superfamily transporter. The third is the small multi-drug resistant system. And the fourth, that is the resistant nodulation division exporter. And five, that is the ABC transporter. So I'm giving some example how that the reduction of uh, concentration of drug that targets cytokine output, right? Some like an example giving the imipenem. So Pseudomonas aeruginosa, right? This organism which is resistant to the anti-pseudomonal carbapenem, imipenem, which is significantly mediated. Why? That is the mutation or a loss of that OPRD origin. So this is the primary means by which the imipenem crosses the outer membrane. In contrast, the meropenem is only minimally affected by the isolated loss of OPRD. So in that case, in anti-Pseudomonas infection, we are giving the meropenem because the imipenem is already resistant because of the mutation of OPRD channels, right? So this is the how that resistance can occur. So this is the first thing. Second, resistant due to the alteration or a destruction of that antibiotic. So, like I'm giving an example of beta-lactamase. Drug inactivations is common mechanism for that drug resistance. So, in that, say that we are a beta-lactam antibiotic through the function of lactamase enzyme. So, over 1,000 distinct beta-lactamases are identified, but resistance is nearly to the beta. So if they are mutated, then definitely the enzymatic inactivation by this enzyme is done, and we are alternative drugs can be given in that case, like glycoside modified enzyme or maybe esterification of macrolides. So we are helpful. Third, that is resistance due to the altered target structure. So target structure. So I'm giving some example of HIV. Right, a common consequences of either a single or a multiple point mutation in the amino acid sequence and conformation of antimicrobial target protein. So in that HIV, there is a chances of frequent alterations of that particular target structure of that cell. So at that time, we are chances of that resistance of antimicrobial agent is high. The last, that is the heteroresistance and viral quasi-species, right? In that case, I'm some giving example of vancomycin. Heteroresistance occurs when a subset of total microbial population is resistant, right? Despite the total population being considered susceptible on that testing, right? If we are a test but some of that microorganism are susceptible, but when total microorganisms are resistant, we are calling it heteroresistant. So in the vancomycin cases, that is the staph vancomycin, which is already we are say that VRSA or MRSA, right? So vancomycin in Staph aureus, Enterococcus faecium, polystyrene in the Acinetobacter baumannii, then rifampin, isoniazid in Mycobacter tuberculosis, they are used in the prolong. If there is the heteroresistance of occurred, like total microbial population is resistant. So these are drug not affected, right? They are not cure the disease at that time. The next thing that is that quasi species, right? So what is that? If there is a viral replication is more error prone than the replication in the bacteria and fungi, right? So viral evaluation under the drug and immune pressure occur relatively easily. So in that case, the variants or quasi species that may contain a drug resistant subpopulation. So this subpopulation is often not termed a historesistant, but the principle is the same. A virus may be considered susceptible to the drug because either phenotypic or genotypic test reveals the lack of that resistance. If we are doing the susceptibility testing, it's showing the susceptible because they have a lack of genome and lack of that resistance that subpopulation is giving. So at that time, the quasi species also having some resistance showing, right? So this minority, and this is the minority population, the minority quasi species that are resistant to the antiretroviral agent that have been associated with the failure of that antiviral therapy. So at that time, we are saying that why the cancer patients, why the antiretroviral therapy is not affected properly, because this kind of quasi species, which is having some subpopulation, and this genotypic phenotypic mutation causing the drug resistance. So this is a detail and depth of that how the resistances occur due to that these four structures, right? And the last but not the least, that is the evolutionary basis of resistant emergence, and this is mainly due to the resistance via the mutation selection and resistance by external acquisitions of genetic element. So how that occurs? So development of resistance via the mutation selection, it's affecting the genetic mechanism, right? So in that case, the antibiotic resistance maybe include the acquisition of genetic element that code for the resistant mechanism, then mutation that develop the antibiotic pressure, consecutive inductions, right? So which are the various factors which occur that mutation? So first, that is the if gene encoding target protein altering its structure. So there is a no longer binding of that drug, right? Second, if that gene is encoding protein, that gene encoding protein involved in the drug transport, right? A gene that is a gene encoding protein is important for the drug activation or its inactivation. And the last fourth, that is the regulatory gene or promoter, which is affecting the expression of the target protein or it's inactivating the enzyme also. So this kind of thing which is affecting the mutation and affecting that particular disease also, right? Microbacterium, tuberculosis, HIV, this is a major uh, factor, right? Also, we are saying that in the pyrimethamine and sulfadoxine, right? That is a sequential step mutation, right? Mutation in that particular, which also resistant the drug. And the second, that is the resistance by external acquisition of genetic element. In that case, that is the resistance in the transduction, transformation, conjugation. That is also resistance in the horizontal transfer of the gene and the vertical transfer of that gene, and which is the affected that particular resistance of antimicrobial agents, right? So this is the how the pharmacogenetics sketch affecting that particular drug resistance. It is, I'm telling in the very brief, but it is having some really in detail. Okay, so this is how that drug resistance can occur. So I'm concluding that first series of antimicrobial therapy, a general principle. So I already teach in the previous video, like what is the antimicrobial agent, which are the categories of antimicrobial therapy according to the stages of disease progression, which are the pharmacokinetic and pharmacodynamic parameter, which is affecting that success or maybe the failure of the antimicrobial agent, impact of susceptibility testing for choosing the particular antibiotic definitive regimen of that antimicrobial and microorganism, then which are the various dose selection, dosing schedule, which also affecting the antimicrobial effectiveness and its concentrations versus the time, and how the resistance can develop of that antimicrobial, which are the various genetic factors which is affecting the various different other factors also affecting that resistance. Despite this, some other factors like irrational prescribing, then proper dose not taken by the patients, there is a missed dose, then also other like proper time to time antibiotic not administered like 6 a.m. to 2 p.m. and 10 p.m. like dosing interval is also variable due to that shifting of that staff, and this is also other practical factors which affecting the resistance too, despite the theoretical aspect, right? So I'm evaluating the more features and more the practical aspect in the next upcoming videos also. So this is the my references of that mean that is based on Gilman and other articles which are PubMed index. So thank you so much for patiently listening to me. I hope that both videos of part A and part B is helpful, or you have learned lots of a thing, not only the pharmacologists, but also the clinicians, surgeons, cardiologists, etc. They are the helpful for the by this video to learn about the general principle, because this is the basic thing, right? After that, we are learning lots of the antimicrobial agents and antibacterial, antiviral, antifungal. But this is the basic thing, that how that all things can affect that patients, the disease, the time, importance of time, importance of the pre-plasma concentrations, then affecting the time of the infection, then time of the diagnosis, sample taking, right? When should to start the microbiological analysis, when to give the antibiotic, right? And which kind of priorities, right? So this is all thing which is affecting that antimicrobial and its resistance, right? Effect versus resistance. So I hope this is the helpful for you. Give a comment for the more suggestions to regarding the antimicrobial. And thank you so much for patiently listening to me. And if you have any query, then contact me on the social media. Please subscribe my channel. And if you really like the content, please give some like and comment to my channels. Thank you so much.